Thank you so much, Mr. Moderator. I think your remarks were more than I could imagine, but thank you so much. First of all, I want to thank the organizers for this opportunity to present this very important, all the big issues around technology and health that was delivered by Dr. Yao Fureji, and also the issues with genomics and personalized medicine that have also been presented. I think the key thing that's coming up is, what time is it now? What time are we in now? Because I think the first presenter was very clear that we started with the agricultural revolution. That was when we were all into farming, very agrarian lifestyles. Then we had the industrial revolution, where it was about how we could get things done, the discovery of the steam engine, first vehicles in this country around the early 1900s. Then we entered the computer revolution, where we saw the first discovery of computers and all that. So the time now is IoT, Internet of Things, AI. So the question is that, at this time, what do we need to do? So this is the outline that we have in terms of our introduction, our 2021 population housing census. That's the good news. We just had a major census. What does it mean for us? Based on all this, since our national health policy, our universal health coverage roadmap, the design innovations we need to think about, and what are the challenges and strategies that confront us. So by way of the healthcare landscape, we had the MDGs, now the SDGs. The UAC is part of is a key agenda that's been driven within the Sustainable Development Goals. And there are three key things. It's indivisible, interlinked, and inextricable. So clearly, with the SDGs, it comes with this interlinked nature of it. And universal health coverage, as we have it, looks at two key things: service coverage and also financial protection. And before we realize that strengthening of our health system is a key thing to ensure that we can achieve universal health coverage and our health security goals, as it were. I think COVID has also brought us certain lessons. As the saying goes, we should never waste a crisis. So the COVID pandemic has brought key lessons that we should always think system. It started as a health calamity, as it were. It became an economic issue. 2020, our GDP per capita, as was projected, was 6.4. After the lockdown, had to be recalibrated to 0.5. Across Africa, it went into negative. So a health problem became an economic issue, became a social issue, and became a security issue. So clearly, health really goes beyond the healthcare sector, and really the future of health is non-health. And then COVID also made us realize that clearly digital health has come, and it has come to stay. We're all virtual. Now Zoom has become virtually a byword, from the coconut seller to the granite seller to the professor. Everybody now uses Zoom across the length and breadth of this country. So like the first presenter said, the IoT has just come to stay, and I think COVID has even facilitated that. So two key revolutions that this has all called for, and I think our organizers were very apt in picking the earlier presentations: the digital revolution, as was presented, and the genomic revolution, and personalized medicine, as Prof. Ahima presented. So Ghana as a country has made inroads with the universal health coverage and also a document to hold all these pieces together, what we call the Global Action Plan for Healthy Lives and Well-being. In fact, His Excellency, the President of the Republic of Ghana, in addition to the Prime Minister of Norway, and Solberg, and the Chancellor of Germany, in fact, former Chancellor of Germany, Angela Merkel, were the key movers of the Global Action Plan for Healthy Lives and Well-being. And four key things it asks for: engage, accelerate, align, and account. And this was a ceremony where they basically showcased it in addition to our development partners. So you can see the Executive Director of UNICEF, the World Bank, Mohamed Petty, Gavi Foundation, Charles Beckley, the DG of WHO, the Prime Minister of Norway, the Honorable Minister of Ghana, Honorable Kukwaj Bamenu, and all the other dignitaries. So clearly, this has been a change in our global health perspectives. We had the MDGs, where we had Goal 4, Goal 5, Goal 6, clearly looking at different parts of health: HIV, TB, malaria, and the other aspects. Then we moved into the SDGs, which, like I said from the beginning, is interlinked, inextricable, all that. And then UAC, as we've tried to capture it in Ghana in terms of our universal health coverage drive and what we could achieve in addition to a national health policy. So the question is, what does the future hold? And this was a slide that was said by Prof. Lem Suangwan, who is a Singaporean. He said, we are in a world that is key for things, volatile, uncertain, complex, and ambiguous. We all don't know tomorrow. So that's even what makes the future of health even more complicated now. No one knows tomorrow. Initially, it was the known knowns where it was cause and effect. If you do this, this will happen. Then we came to what they call the known unknowns, where it was business schools started teaching scenario planning. If this happens, you go that way. If that happens, you go this way. Now we are in what they call the known unknowns, where we don't even know what will happen to even plan what you need to do. So when it comes to unknown unknowns, then agility and responsiveness are key attributes that need to be picked up on in the health sector if we are to move. And then the fact that technology is moving very fast, I think our first presenter was extremely clear around it. And also geopolitics presenting great uncertainty. A few months ago, we already envisaged Russia, Ukraine, and nobody even knows tomorrow what's going to happen and all that. So really, complications around geopolitics, health security, fragile countries, fragile settings, issue of migration, refugees. I'm sure Poland didn't envisage getting 2 million refugees within a very short time. But that's what geopolitics presents in a different aspect of geopolitics, as it were. So really now, we don't need a map, but we need a compass. We need more of culture and values, because the culture and values that will always evolve, as it were, and enable us to catch up. So what do we need to prepare for this future? Gradually, we are seeing that Ghanaians, we are all aging more, life expectancy is going up, so aging is becoming a bigger and bigger issue. And if I heard the second presenter very right, type 2 diabetes, aging is also one of the preconditions, meaning that if we are all to age a bit more, we are all a bit more predisposed. Family formation, the income wealth, social divide, homes, more health crisis. The COP26 was just held in Scotland a few months ago, climate shocks and all the climate change issues. And I'm sure we even see it around us. When we're young, the rainy seasons as we knew today is clearly different. And we see it everywhere we pass. So climate change and the health impact of climate change is also real. Cyber attacks, geopolitical conflicts, geoeconomic competition. And we don't know what we don't need to know. Like I said, unknown unknowns. So what did the population housing census present? I'm sure we are all aware that now the population has moved to close to over 30 million now. The key thing that has come out from the population census is the fact that urban health needs to be looked at. Before last population census, Eastern region was the population with the largest number of people. It moved to Ashanti in the last population census. This current population census is clearly showing that Greater Accra has taken over as the region with the largest number of people. What's even more interesting with the population census is 4 regions in Ghana now are constituting close to about 54% of the population. Greater Accra, Ashanti, Eastern, and Central. If you look at Eastern and Central, these are the parts, the district bordering Accra. So now Central all the way to about Kaswa, the Kaswa area going to the Wutu area are huge populations who virtually live and work in Accra. And then you see same in Eastern going to Koforidua area. And also now, virtually where I come from, the Kwapim area is virtually joining Accra as well, right across the Odua and from Ebri. So clearly, urban health is coming up as a big area that we need to look at. The same census came out so that the number of people who live in shelters and unidentified homes have increased in these urban areas. And then we're also seeing even in areas like East Legon, where we want to term as middle class areas. But right between those mansions, you see people who live in squalors and behind those houses and all that. So really, you might think that even health conditions are good, but there are people there who are living in 14th century conditions, side by side, in 21st century lifestyle. So clearly, it even becomes that, like the UAC says, leave no one behind. We might be leaving a lot of people behind in terms of our targeting because of the nature of the populations that are evolving. So in terms of residential proximity to health facilities, clearly it was seen that from the population house census that even in the Savannah region had huge disparities in terms of having access to health facilities. So clearly, you could see even a bit similar in the Oti region and all that. So clearly, access to healthcare has become a challenge. What is even more interesting, if you go a bit further into the data, is the fact that some of the population are migratory populations. I've met people from some of these regions who are in Ankrah after the planting season, and they go back into these regions when the planting season is on. So they are even migrating between two different regions at different times and lack access in all these areas. And there's also residential proximity to health facilities. It's virtually showing the same trends as I showed with the previous graph. So based on all these things, we developed a national health policy, and we were thinking that, look, the future of health is really non-health as it were, and it's going to now look at things from a very broader perspective. So one, how do we strengthen the healthcare delivery system to resilient, taking cognizance of all personalized precision medicine as we have heard, the whole area of IT in health and all that. How do we encourage adoption of healthy lifestyles? Because whereas the bulk of the coins that we see from a public health perspective, diet plays a huge role. And if you're able to work well with the Ministry of Food and Agriculture, Ministry of Lands and Natural Resources and all that, we should be able to make some inroads in this area. How do we improve the fiscal environment in terms of housing settlement, broadly and all that? And clearly you can say this thing doesn't fall within the realm of the health sector. We need to be able to work more with works and housing and other industries or other agencies which are more clearly involved in improving the fiscal environment. And how do we improve the socio-economic status of the population? I hear that when money is not in people's pockets, they start getting a bit unwell. So how do we improve the socio-economic status of the population to ensure that it gets improved? And last but not the least, how do we ensure sustainable financing for health? The cost for healthcare is also increasingly becoming more and more expensive. In fact, medical inflation is even a bit higher than normal inflation. So that is that ensuring sustainable financing for health is something we really want to look at closely. So after having done all this, Ghana spent close to a year, 6 months thereabout to agree on a national definition for universal health coverage. What does universal health coverage mean to the Ghanaian? So the Ghanaian definition is that all people in Ghana should have timely access to high quality health services, irrespective of the ability to pay at the point of use. So if you look at the Ghanaian definition, access has been qualified with timeliness because we've picked all the services: emergency care, mental health, preventive medicine, palliative, rehabilitative, curative care, and promotive health services. So all the services, we want a Ghanaian to have access to it. But we realize that especially in the context of emergency care, time is of the essence. So that's why the access has been qualified with timeliness. So if the patient is not seen on time or something is not done within some time frame, we'll end up losing the person. And then access to high quality health services. So not just quality health services, but high quality health services. So we are looking at how do we deliver to the Ghanaian health services that are at par to every other part of the globe. And that means a lot. That means that we need to even start looking at some of our hospitals getting GCI accreditation, certain accreditation seals that will enhance the delivery of certain services at a certain wavelength. And then irrespective of the ability to pay at the point of use. So we are not saying that the Ghanaians are not averse to payment, but how do we ensure that at the point of ill health, that person should be able to have access to those health services and then cost not being an issue. And that's why you've seen all the various reforms government is doing with the national health insurance and other forms, mental health being paid directly to ensure that we're able to do this. But that's not to say that we are there yet. There's still a huge gap and there's still more we have to do collectively to be able to bring the cost of health services down. And that's why I really like what the previous speakers have said around, and let's look at the long-term cost of our telemedicine service and other services, whether it doesn't really help bring our cost services down. And I think this is a conversation we can pick up a bit later on. So these were the goals. We want to ensure increased access to quality essential healthcare and public health services for all by 2030. And basically to ensure increased access to better managed quality services, ensure universal access to interventions aimed at reducing maternal, newborn, child, adolescent deaths and disabilities, and universal access to clinical and public health emergencies. So really, it's not just about clinical or public health emergencies. Because one of the gaps we also realized is that clinical medicine, public health medicine seems to have been side by side. How do we all sit around the same table? to look at the issues from a broad perspective together. And these were the guiding principles, ensuring that we leave no one out within the true spirit of sustainable development goals. Financial risk protection, as I mentioned, to ensure funds doesn't become a blockade to people acquiring health services. Building strategic partnerships, this is very key. Actually, goal 17 of the Sustainable Development Goals talks about strategic partnerships, and we need to move this rhetoric into reality. So how do we ensure a harmonious agenda between government, private sector, non-state actors, and development partners? Within a broad thinking of our Ghana Beyond Aid agenda, effective decentralized management, how do we ensure our health services are decentralized to the basic minimum? We have all the services that I mentioned, preventive, palliative care, rehabilitative. In fact, with our analysis with the experts, we realized that in the area of palliative and rehabilitative care, we were really, really down in terms of even the infrastructure, not talk about the personnel. So the colleges have started doing something, but we are still a very long way to really get to where we will consider optimal, as it were. And then looking at how we reprioritize our domestic financing to ensure we have more funds for our healthcare delivery. So these are the services I mentioned, the curative care services, our preventive services, promotive care, rehabilitative care, palliative care, emergency care, mental health. So these are all the services that is being taught through within our essential health services package. And for your information, we just validated the Ghana Essential Health Services package around all these services as we speak now. They're thinking that this will help inform, shape our benefit package within our National Health Insurance Scheme, and then look for different sources of funding to fund the rest. Ghana is also developing a medical tourism policy to start seeing, I'm sure we heard the last state of the national address, repositioning Ghana as a medical tourism hub for the sub-region, to start seeing how we can get some of the services, the high-end services, especially for the teaching hospitals, to reposition themselves. We need a broad vision of our teaching hospitals. Okay. The other thing we've also realized that we need to be, like I said from the beginning, what time is it? And the 21st century is also the age of design. So we really need to also look at the design of our systems. And I think Dr. Fueje raised a point that it's not just about getting the softwares, it's about the systems and the system redesigning. And we need to look at it from the three perspectives, the systems perspective, the environment, and processes. So this needs to be thought through fully and not just bringing in another software or whatever. And clearly, disruptive innovations are also becoming very key. And even looking at our hospitals, we need to start thinking about redesigning of hospitals going into the future. Because a lot more is changing based on the time we find ourselves in now. How do we redesign our hospitals to be the hospitals of the future? Now, increasingly, I remember when I joined the ministry at first, we could do hospitals and IT infrastructure was not too much in. Today we do hospital and IT infrastructure is so huge that we don't even have the IT professionals in the health sector. Because always we are talking about doctors, nurses, pharmacists. But really we need to look at even the scheme of service for a cadre of IT professionals in the health sector that we will have to gradually promote, train to be fit for purpose for the health sector. Otherwise, a lot of this facility can be built, but realize that a lot of things cannot be deployed because even the personnel are not there to be able to live to the expectations the hospital may require. So one of the design innovations we've also thought through, which we're still moving on, is what we call the network of practice, where from the front line, the community-based health and planning services will link up with the health center so that there's a kind of monitoring mechanism over it, so that the manager in the health center knows that he has oversight over their CHIPS compound. Once or twice a week, he goes to see what is happening there, follows up with their care of patients and all that. Because clearly the Ghanaian wants to be able to go into this system and make sure that he's getting the preventive services, he's getting the promotive services, he's getting the creative services, he's getting the rehabilitative services. And so it is repositioned in a way that's attractive to the Ghanaian. I'm sure most of us seated here don't even go to the CHIPS compounds. You always want to go to the hospital. So how do we ensure that we can create a health system where you go is the same place that poor woman on the street will also go? Because we all deserve the same kind of health services. And that's the kind of repositioning we are trying to do. It's interesting to note that with the formation of our health system in 1957, and the only Ghanaian who was on the board, the Mord Commission report was K.G. Konwa, the founder of Ankrah Academy. And one of the things they recommended in 1956 was to have a health system where the teaching hospitals were supposed to have oversight of the regional hospitals. The regional hospitals were supposed to have oversight of the district hospitals. In fact, when I got those records, I felt very sad that almost 62 years after independence, we still go back and we are already thinking about these things. So clearly, how do we move policy from the table into action? And then that policy implementation lacunae is something we need to watch very closely and see how we can bridge that gap. That's it. So these are the systems, like I mentioned, that interconnectiveness between all the systems will be there. So these are some of the few challenges that confront us in our quest to achieve universal health coverage. Financing, is the biggest block, as with any other low middle income country. And then with the challenges COVID is presenting itself now, financing is becoming a bigger issue. Heavy burden for domestic resource mobilization. And we really need innovative financing ideas now, new partnerships. And that's why we think we should look at do some more economic evaluation around some of the new IT innovations. Maybe in the long term, it tends to be more cost effective if we do it with budget impact analysis and see how it plays out. Then quality of care. How do we need to increase public confidence in health services? How do we address some of the extra cost out-of-pocket issues that we normally talk about? In leaving no one behind, I think innovation and technology is key. I remember when the Northeast region, and there are areas they call overseas regions. When you go to Northeast, overseas, really, when it even rains, even their tomatoes cannot come back to the market. They can't even access any health services. And these are areas where technology becomes very key. Now, virtually, in fact, when I go to some of these very deprived places on my monitoring rounds, the kind of sophisticated phones they use, like I don't even have those phones. So clearly, you don't even need education to know how to use all of these sophisticated phones. And if we can deploy the needed technologies on these phones, really, access to healthcare will be more than bridge, as it were, especially in some of this. And we have huge island communities on the Water Lake. I don't know, some of you have visited before. Rivering communities that huge populations live. They do yam farming in Ketekrachi and beyond. And some of them who cross from Yeji onto those islands all the way to Akosombo. And huge communities who live on these islands. How do we ensure access to them using deploying some of these technologies and all that? And then how do we strengthen our partnership with the private sector? And also, most importantly, how do we respond to our emerging health needs? Now that more and more people are aging, geriatric healthcare and all that domain. So as a sector, these are some of the strategies we realized we want to embark upon. We need to see health as an investment and not an expenditure, because the lessons of COVID are clear, that the health problem became an economic issue, became a security issue, became a social issue. So really, investment in health is an investment. And that our services should also be people-centered and not disease-centric. And this is what we are working on with our developed national quality health strategy, which we are deploying across the country, training the quality teams and all that, and also strengthen our regulatory institutions that ensure quality, i.e. the Medical and Dental Council, the Pharmacy Council, the Health Facility Regulatory Agency, that ensures that our healthcare facilities have certain standards and all that. And also, now even Medical and Dental Council is thinking about licentiate exams for doctors, regardless of the medical school you graduated from. You should have some broad exams to ensure quality of our professionals. And also the Pharmacy Council look at how these professionals can be. Because HR is key. Like someone once said, you build a nice place and you put in prisoners, it becomes a prison. So what makes it a hospital is the human beings and how well trained they are and of which standards do they conform. And that's what we need to work on and have a shift a bit from the brick and mortar. Our approach to health delivery should be more comprehensive, leveraging the potential of traditional and alternative medicines. I remember once we were in Senegal and somebody asked a question that I kept thinking about it, so I arrived in this country. The guy was very clear. He said, when I go back, I should look at the relationship between the doctor and the patient, and the herbalist and the patient. And I thought he was joking, but when I thought, I was like, it's interesting. Because the herbalist, you come to the herbalist, he asks you, what is happening here? It's more informal, and patients are at ease. And people see entering the typical medical institution as a bit more distant. So we need to bridge that gap and see how we improve upon the quality of care and relationship. We also need to refocus government primary role from sole service provider towards stewardship of our overall development of the health system. And this is something as a ministry we are working on and gradually moving away from. And then the delivery of healthcare cannot be business as usual. Like I mentioned, the 21st century is the age of design. How do we look at the redesign? And that clear thinking about the design innovations we need to put in place should precede whatever thing we put in. So clearly, I want to end up with what Prof. Flame said again. He said, we always need to think people, we need to think future, and we need to think excellence. We need to strive to be the best that we can be. Okay. So I will leave this slide. I won't speak about it. Thank you.